el doctor Hamid Reza Marateb, que pertenece al BIOsignal Analysis of Rehabilitation and Therapy Research Group de la Universidad Politécnica de Cataluña. Y su charla va a tratar de aspectos de la inteligencia artificial y su aplicación, como acabo de comentar, en el ámbito biomédico. Voy a darle paso al doctor Marateb. Hi.
Hello.
Hello.
You can hear me?
Yeah. Check if you can share your screen, please. We can hear you. We can see you. So far, so good.
Okay, good. Thank you very much.
That's perfect. So, Hamid, tell us something about you, because my introduction was very short.
Okay. Thank you very much. I'm a fellow researcher in a BIOART group, BIOsignal Analysis for Rehabilitation and Therapy Research Group from UPS. And this presentation is about artificial intelligence and biomedical engineering applications, and I will focus on specifically medical data mining. Okay, so shall I start?
Yes, a moment, if you can wait for 1 minute.
Okay, sure.
So, and what was your thesis, your doctoral thesis about?
Yes, my PhD was about neural decoding. It was about neuroscience.
Mm-hmm.
So I was working on decoding commands coming from brain to the muscles.
Uh-huh.
It was performed in Italy, Denmark, and Stanford University. So I was in 3 institutions. And I'm also an associate professor in one of the universities in Iran. So it's like I have 2 different affiliations, and we collaborate on medical data mining with different centers in Europe, Canada, and United States. So I'm going to bring some applications and some important challenges and you know, the topics that are interesting for people who are going to use artificial intelligence in medicine.
Yeah. Well, interesting. Quite interesting.
Okay, thank you.
So, I think that now we are on time, so whenever you want, you can start.
Okay, perfect.
Thank you very much again, Hamid, for giving this talk to us. Yeah, thank you.
Okay, you're welcome. It will be about 50 minutes. So, good evening, everybody. We have been focusing on many different research questions in the field of medicine. So as you can see, artificial intelligence is a very broad topic. And one of the concepts is the machine learning. And in machine learning, people usually focus on 2 different applications. It's called clustering and classification. With classification, you would like to predict, you know, you have some training data and you would like to use it and train your system and predict the future event. And with clustering, you are trying to see how many groups are in the population. We have been focusing on the following topics, from neurosciences to different aspects of medicine, with the focus on clustering, diagnosis, prognosis, and I'm going to provide some examples and some important links from medicine to engineering and biostatistics. And I would like to talk about the importance of considering biostatistics in artificial intelligence studies whose outcomes are being used in the Society for Public Health and Medicine. So the concepts of using artificial intelligence, if you check this concept in different books, for example, one of these books, you will see chapters like this, like is the design of those systems, from design to validation, the addition of biomedical engineering and informatics and healthcare application, we call medical artificial intelligence system. So basically, it starts from design to validation, and it can be used in different aspects of diagnosis and prognosis. Okay, so what about the important issues? Okay, in engineering, we can use artificial intelligence in broad topics, but when it comes to medicine, because the output of our system is being used by medical doctors and clinicians and might be used for health policymakers, we really need to pay attention to many specific items. Otherwise, the output of the system is not usable, and people won't rely on our outcome. So what are the extra topics? I mean, artificial intelligence has its own complexities and problems to design and validate. But when it comes to medicine, the model has to be interpreted. The model interpretability for clinicians is also important. And how the data is integrated. I mean, we recently participated in one of these workshops by the Intellectual Property Committee from Europe, and they were talking about the integration of medical data to the artificial intelligence and deep learning models and its regulations. So when you want to design something so people can use everywhere, you have to really think about this integration. The validation, yes, we have the validation frameworks in engineering, especially in machine learning, but when it comes to medicine, we have to report specific items. We have to pay attention what they would like to see from our system, and the clinical reliability. So if the system is not reliable, it is not going to be used in hospitals, in clinical centers, or by clinicians, and it would be just a paper that is published or a thesis, and it cannot be used in the society, because the aim is using this system, and we need to pay attention to the concepts. Well, there are many protocols in medicine, like a STARD. You know, if you want to publish a paper related to diagnosis in clinical journals and medical journals, and specifically top medical journals, they will force you to use a specific standard like a STARD, a STROBE, and other like tripod, and there are many different standards. But now they understand that artificial intelligence is everywhere, and now they are working on the STARD AI protocol. And there are some papers in Nature and some BMJ journal, they are talking about this. So they are going to adapt the concepts that they provided for everybody to design a diagnosis system, the different validation, to consider artificial intelligence. So it's a very important topic. And if you would like to work on this area, it is very important to study and explore these standards to see what to report, what is important, and something like this. Okay, artificial intelligence, specifically machine learning, has a lot of applications. Like specifically now in precision cardiovascular medicine and event-based medicine. So it's like medical field has been changed, and now we have precision medicine. Now we have targeted medicine. So it's like the treatment is specialized for a specific person based on some specific features. And this is where machine learning is being used. And as I said, there are two main topics. One of them is ontology, and the other field is diagnosis and prognosis. Ontology is like this. Suppose that you have functional gastrointestinal disorder. I mean, doctors, they call it FGID. It's like there is no bacteria responsible for that, and you really don't know. You have acid reflux, your digestion system doesn't work, and no virus or bacteria is responsible for that. So the treatment is hard because the cause is not really clear. And the way different specific FGIDs like IBS and other different types are defined is based on the questionnaires and people fill in a large population, and they try to find groups of people with similar symptoms, and then they try to define each group with a name, which is called clustering. It means you don't have any labels, you don't have any gold standard. You really don't know how many classes are in your data, but the classification is pretty different. You would like to diagnose a problem, a disorder. You would like to provide prognosis. You would like to provide the efficiency of treatments using different machine learning methods, which is called prognosis, and diagnosis and prognosis are all part of the classification. So they are also considered as big data. And as I mentioned, we have supervised learning and unsupervised learning. There is also the third category, which is called reinforced learning, but I will focus on the first two. The problem is that most of the engineers, they would like to use classification system without paying attention to the time information. So if you would like to, for example, diagnose a cardiovascular disorder, you consider some features, and then you would like to predict if somebody has coronary artery disease or not. And we really don't care about the time to events. I mean, from the baseline to the occurrence of the event, this time is different from different people. And this time, if we do not pay attention to the time to events model, we might produce something that is not usable at all in the field of medicine. I will bring some examples about that. So we really need to pay attention to time to events model, specifically called in medicine and biostatistics, it's called survival models, in which artificial intelligence can be linked. I will talk about that later. Okay, before going through this work example, I would like to bring another example. I hope that you can see this screen.
Yeah.
Can you? Okay,
I think that we can see it. Yeah.
Okay, perfect. So this is a rather different example in the field of neuroscience, and it's a field of brain engineering. So I would like to bring some issues about artificial intelligence in practice, and then I will go back to data mining. So this is another example. Actually, artificial intelligence basically means that you design a program that imitates what human can do. So if you design a program that can imitate the work of an expert working on a program that is like interactive program, it is also called artificial intelligence. This is one of the examples. Suppose that we recorded a signal from a muscle with an electrode. This is the signal, okay? And basically they come from brain through spinal cord to our muscles. And they are commands to the muscle, so they try to basically tell to the muscle to contract. How much contraction is required? Which part of your muscle should be activated? And a lot of different issues. So this is the signal. This is the signal that we record from the EMG, from the electrode that is put inside the muscle. If we look closely to the signal, we might be able to see that there are some, let's say, very similar patterns in the data. So if I see, I would say this one is repeating. Yes, I'm using an interactive program. So it's like, okay, I see another one, I put it as a template. What I'm doing is just I'm performing some kinds of clustering. I put this template here, and I look for, okay, here, it seems that it's also, we have also similar here. So I put it here. So what I'm putting here, and you can see that the residual is very low, so it fits very well, and it is closely related here. It's like there are some motor nerves, and they are firing through the signal. So they are activated in different times. We can do it for other parts. Look here, I put it and I select it as a template here. And whenever I see something similar, I put it there. And the algorithm says, okay, nice, it fits. So we can continue through the signal and do this. For example, here, you can see something similar happens. So what I'm doing actually is clustering and then classification. I'm trying to find the number of classes, and then I will try to assign them to the classes. And it's a pretty time-consuming procedure, especially if you want to do it all manually. And there would be some even worse problems like this, because it's possible that some some nerves are activated at the same time. So their information would be overlapped, and the shape of this is not really similar to none of them. Then you have to use another method to identify the ingredients templates. Well, it's very hard. But now, if you do it automatically, so if you write a program that will find and fill everything automatically by imitating the human operator like this, then, well, it seems that it's all done, right? Here, there are 2 units. This is 1 unit. This is 2 units, and you will see the firings here with the circle. Here, unit 1, 5, 4, 7, 2, they fired, and you can see them, especially here is also very hard. 6, 5, 3, and 1. And it automatically identified all of them. So you can see the residual is very low, and the algorithm identified all of the units from the signal. Now you know how many nerves were activated by the spinal cord. And now you even know the timing of all of them. And then you can calculate the frequency. And this is how the neural system controls our muscles, by changing the number of units and the frequency of the firing. So basically, we designed a program to imitate what somebody is doing, operator, but it is much faster. And the level of tiredness doesn't affect the performance of the algorithm, because we just took the rules of the human operator, and we use machine learning and also expert-based system and mix them together. This is how machine learning and artificial intelligence can help in neuroscience. So this is just one example. Let's get back to our presentation. Now we get back to the medical data. Well, usually people work on the cohort data, and I will bring some COVID-19 examples, because now it's very important. So some of my examples basically are related to COVID-19. So there are some people who go to hospital, and if their PCR test is positive, or the CT scan tells that they have, some of the lungs are infected or are involved, they are admitted. And then they will be in the hospital, and they would be in hospital until they die, or hopefully they are discharged alive. And when they discharge alive, there would be different follow-ups at time, for example, first week, fourth week, 12th week, and 1 year, to identify if they are still alive, if they have symptoms, or something like this. So this is one of the typical cohorts that are used for COVID-19. So there are specific research questions that are being answered by artificial intelligence, and I would like to bring them, and I would like to talk about the problems that happen if we do not pay attention to the specific medical suggestions and biostatistical issues. One of them is the diagnosis. Well, usually the diagnosis is performed by PCR test, which is not always correct. And sometimes the CT scan is also included. Maybe it's better to have some app that can predict if somebody has COVID-19 based on just blood samples. This is something that people were doing in the literature. If you see the papers, they are trying to design systems to use symptoms of people, blood samples, and family histories, and they are trying to predict if somebody has COVID-19 or not. One of the issues that is important in clinical practice is to provide ranking of the features. So you should really tell them which feature is the most important one. But the problem is that for machine learning, it depends on the data that is used to train the system. So for example, if you use the 50% of the data, the first part for training, you might get some features that are not really the same if you use the other 50% for training. You cannot use the whole data for training because for sure you will have overfitting. So you cannot really generalize your results. That's why methods like called stable feature selections, for example, this one is a stability feature selection, can help. So always try to think about the stable feature selection that are somehow robust to different folds of the data when the features are selected. This is one of the issues. So this is one of the methods that we provided and some of the results. But the point is that think about a stable feature selection, not about the traditional feature selection that are really, really sensitive to the amount of data and the permutation of the data. Another issue is the risk assessment procedure. Risk assessment is like you have a cohort of patients and you follow them from the baseline until 50 years, 15 years, or until 30 days. And then you would like to predict some outcome based on the baseline characteristic. This is one of the risk charts that can be useful, and people in medicine, they really like it because the output is completely interpretable. The output is the plot. Okay, you might report the performance of your system, the many different plots, everything, but if they cannot bring connection from their findings and your system, and if they think that your system is a black box, you are in danger because they do not rely on black box. They want to see something that has rules or at least some charts describing its behavior. This is one of the charts that people usually in the field of infectious disease and especially in the field of cardiovascular medicine, they really like it. It's like a plot that has a specific symptoms, a specific features like blood pressure, like waist to hip ratio, if person has diabetes or not, or if it's men, he is man or she's women. So many very simplified plot. It doesn't really need any blood test, right? They are just features that everybody can check at home. and then it will tell you in the next 10 years what is the risk of having cardiovascular disease. So basically, you can see your condition and see the color, and also we have the age categories here. You can see your percentage, your risk. And then you will be able to assess your condition by, for example, increasing your physical activity, working on your blood pressure, and for example, also a smoker and non-smoker, I just forgot that, we also have the symptoms. So you can clearly see that here we go up to 58%, and here we go about 1%. So it's a very nice chart. You can have it at home, or clinicians can have it in the lab, or in the hospital, and people can see the risk. This is called out of hospital data. This is the time to events model. It's not a classification problem. You cannot get something like this with classification whose probabilities are clinically interpretable. Some of the classification models, they can report probability, but clinicians, they don't accept this probability. This is based on Cox regression model. This is one of the type of, machine learning is used for classification and regression. So if you want to work on the survival models that has events and time to events, we really need to think about regression, and this is called the Cox regression models. And of course, it can be implemented online because it's very simple. The result of the regression is very simple, and everybody can trust because it's simple. This is out of hospital data. But when it goes to in-hospital data, for example, if the people who are admitted to the hospital and they are either discharged alive or they die in a specific amount of time, you can also create another plot, which is risk chart, but with a completely different approach, which is called the competing risk models. Well, if you want to use traditional machine learning methods, they neglect people who are still alive in the hospital. So if you take a time frame of 30 days or 60 days, it's possible that some people are still in the hospital and you really don't know what happens after the time frame. You have to neglect them. And in this time frame, you have to consider the class with the people who died and the class with the people who discharged alive. But what about people who are still in the hospital? Traditional machine learning methods, they cannot model this. So there would be a bias. You might throw this data, which is not correct. And you have to use a specific type of modeling, which is called competing risk methods. So how can AI help this? Well, this is basically the biostatistical model, but you can use machine learning and identify, for example, instead of saturation, oxygen, maybe there would be a very good interaction that could be nonlinear between this symptom and the, for example, LDH of the blood, or other types of the inflammatory markers in the blood. Traditional method cannot do this, that you have to consider just one symptom. But if you use artificial intelligence in addition to the competing risk methods, you might be able to provide the best interaction of the features in order to maximize the performance of the model. So this is where artificial intelligence can help traditional biostatistical model, but you really need to be careful that you are working on survival modeling, which is not a simple classification problem. Another area that could be helpful is some networks that can identify the interaction of the features. This is another example. Suppose that this is a nice example for children and adolescents. Suppose that you have some children at school and adolescents, large population, and you record some of the very, you know, basic features, including obesity, age category, self-rated health, beverage consumption, and, for example, type of diet, and voice, and so on. And then during the time frame of 5 years, and some point, they are screened for a specific psychiatric symptoms like depression. But you know, children and adolescents, for children specifically, these symptoms are mild, but in future, those having these symptoms might end up with severe problems like depression, you know, and anxiety. So there are specific questionnaires from WHO, so you can measure them during time. And then you design a network that can predict if somebody can have depression in 5 years. And then you use a specific type of network, which is called GMDH, called Group Method of Data Handling. It's part of the deep learning algorithms whose nodes are automatically identified by least squares, so they are not stochastic. And you also add the stability feature selection into it, so the results would be somehow similar in different folds. And then you identify, for example, the interaction between self-rated health and abdominal obesity is important. Such nonlinear interaction, because this least square has the polynomial function, but it will be solved by the traditional least square, or in this case, some regularized least square in order to minimize the weight. Then you will be able to have a network that is capable of predicting if person will have depression or not. So it's like a screening. Of course, it is not cause and effect, but there are associations between these symptoms and the outcome that is helpful to prevent some outcome later, because it would be a burden for the health policymakers and families. It's much better to, you know, prevent it from the beginning. So if really beverage consumption is problematic, so you design the program and you put the features, and then it predicts if the person will get depression or not. And if just changing beverage from 0 to 1 changes it from no depression to depression, then you would say reduce the amount of beverage that you are consuming. So it's like working on modifiable risk factors with machine learning for health. Well, prognosis is a much harder problem than diagnosis, because there are a lot of complexities in the model. It's like it's the onset, which is when the person is admitted to the hospital. Maybe he has mild condition, hopefully it's the case. And after some days, he will be discharged and go at home to quarantine himself, or self-care at home. Or maybe from mild goes to moderate. Hopefully it will return to mild condition, but from moderate to severe, it's a two-way, from severe to critical, and unfortunately it can end up with this. Well, and we have a specific part of the hospital, which is the intensive care unit. So they are also part of the modeling. So in the hospital, patient might be discharged to home, or it will go to ICU, or unfortunately it will go to ventilation, or end up with death. Or ventilation will help the patient go to the ward and go to home. Well, from machine learning point of view, it's a multi-state model. So if somebody would like to predict the survival of the patient with the baseline characteristic, he shouldn't really go through to traditional classification like LDA, SVM, or many other different classifiers are like neural networks, because they do not consider the states, they do not consider the time to event, and the output is, okay, the output, okay, you would like to predict based on the baseline characteristics if the person will die or not. This is the only suitable information that you might produce if the model is clinically reliable. Okay, let me just bring this one. If the model is clinically reliable, so a clinician would like the sensitivity should be high, a specificity should be high, positive predictive value, negative predictive value, and AUC, and finally diagnostic odds ratio, because they are a specific threshold in medicine. So if they do not fit this threshold, they do not consider it a clinical reliable system. So even if your system is clinically reliable and can produce a very, very high amount of very high performance indices, then you can just produce the information about the event and you do not consider time to event. Still, you will have the problem of the framework, your time frame. You might say that, okay, I would increase this time frame until no patient is still in the hospital. But if you increase your time frame, you will lose your precision, because local information will be lost. So it's always a matter of problem with the traditional machine learning that do not consider time to event. Some random forest algorithms are being used as random survival forest, but they cannot produce some basic information that are required by clinician. So the multi-state model analysis are not only used for many different multi-state problems in medicine and solving financial problem or any specific part. You can even see their usage in physics, but they can answer some of the key questions that are very important for the hospitals. I mean, suppose that there is a pandemic like COVID-19 in future, which is possible, because now we would say everything is possible. So you would like to predict the length of intensive care, duration of invasive ventilation, and mortality in your hospital. So in 60 days, if you want to predict how many ICU beds are occupied within 30 days, the only method that can help is multi-state models. It's based on the Markov chain. I will talk about this later. Even if you want to analyze the efficiency of the treatments, there are a lot of papers you can see in the literature talking about the treatment problems, the biases that occur with traditional, simple machine learning and statistical models. Multi-state model solves all of them, all of the biases at the same time, because it's a mixture of biostatistics and machine learning. So it's where they are combined. It avoids misinterpretation and biases. It considers the competing risk bias. It's like the person can be either discharged or die or be in the hospital still alive. The third one, which is the much more important, is the time-dependent bias. It reduces the time-dependent bias. It's like the patient who is in the hospital. If somebody would like to predict if the person dies and uses just the baseline characteristic like age, amount of inflammatory markers, the family history, and symptoms, he or she cannot include the treatments that the patient got after the baseline. But the problem is that the treatment line is different from one person to another. So and also the joint use of treatment, like the vitamin C and antiviral disease treatment, they could be served together or with 1 day difference. They are called time-dependent variables. You cannot just add them in your model, like if the person got vitamin C or not, or how many vitamin C shots he got. But they are time-dependent. Their performance depends on their time of usage and also the time of using other medicine as well. So it can model also time-dependent phenomena. And also it avoids selection bias. And as I mentioned, because we usually with machine learning, we exclude active cases, those cases that are still in the hospital, but the multi-state model can consider these also in the modeling. So basically it's a multi-state model with limited states. Suppose that the person goes to the ward. It is being served by the non-high pressure oxygen. Well, hopefully we'll get well and will be discharged. Or unfortunately, if it doesn't help and the oxygen saturation is dropped by a certain amount, mechanical ventilation has to be used. Or maybe the person will have some inflammation, and because of the inflammation, he will get arrest. He will have arrest and will die. From the mechanical ventilation, maybe he get better, he returns to the non-mechanical ventilation, or will be okay, go to discharge or die. So you will have two states here, death or discharge, and you will have two states here, like mechanical ventilation and non-mechanical ventilation. You can increase the number of states if you want. You can add a ICU admission in this block as intermediate stage. You can also even add the wards of the hospital, and you can increase the complexity, but we have to be very careful because the parameters of the model must be estimated, and if you increase the complexity, you need a lot of more data. Here, Markov models could be used, or if they don't fit properly, it is possible to use an extension. I mean, a very good paper about this is the multi-state models, a review. So it talks about different Markov models and their extension. So what are the outputs? Very nice outputs for clinicians and for the hospital. It's like, let's focus on these two. This is one of the outputs, which is called a stack probability plot. It's like the probability plot for different outcomes, like discharge, hospital admission, ICU, ventilation, or death, with different colors. But we have two different stack probability plot here. The left one is for those whose neutrophil to lymphocyte ratio was less than 5.3, about 452 patients. And this is related to those whose neutrophil to lymphocyte ratio was more than 5.3. Well, you can see, okay. The gray is the probability of death. In the right one, you will see that by increasing the time, the probability of death increases. And you can even say the probability at different times after admission to the hospital. And this one in green, in red, is the ICU admission. Okay, so you can see the ICU admission of these two patient categories are different. Based on the prevalence of these two categories, you can later predict the probability, and you can say, for example, because those 182 patients divided by the total population is the probability of people with these in this category, For this category, for example, I will have the peak of ICU in 8 days. And the peak is about 30%, the probability. It creates a lot of probability values, and then you will have another table, which is the result. It's like in average, people were in the hospital for 10 days. In average, people who started without mechanical ventilation, they were in the hospital for 16 days. And there are many different information and the risk of this. So you will provide for your health policymakers, when do you predict, because you will have a time frame of the data, and then you can predict based on this. For example, for the first wave, I will predict that in 5 days, you will need, for example, 230 ICU beds in a city. And then you would say that the probability of that people require to have mechanical ventilation is this amount. And you know it's automatically calculated. So this is something that people in Germany were using, and there were clusters, and they were using this multi-state models. We are now trying to incorporate it into a program to be used for the hospital, because it is an automatic program. And also you can use artificial intelligence to include features and their interaction into the model. This is another plot for lymphopenia. For the lymphopenia, here, people who have lymphopenia, people who don't, and you see, you know, this one, the gray one is the death probability. This is the ICU admission probability. And this is for those that don't have lymphopenia. And it is completely clear, the difference based on this, and you have values in days and the peak value. So you can predict the peak of the ICU in a city. And this is also based on the Charleston Comorbidity Index, which is an index of comorbidity or the history of diseases that you have. And it shows that when the comorbidities increases, the deaths and the ICU admission increases, and you have different peaks and different probabilities. Well, we really need to focus on specific items. Now I bring just a very fast case studies, and I talk about the problems of using artificial intelligence in medicine. These are the issue of the focus. We have to focus on this: experimental design, validation and performance index, for classification, for regression, and type of statistical tests that are required to convince medical doctors and health policymakers that your method is usable in the field of medicine and clinical studies. You always need to think about experimental design, like sample size estimation. Usually engineers don't care. We just include 30 subjects for one category, 50 for another category, and we do not consider sample size estimation. Well, in clinical sample size tables, there are not much information for us. But if we go through specific papers and book chapters talking about their importance in medical data mining and machine learning, we learn that they are very important, and you should really take care of that. And the sampling, where they sampled, they were randomly sampled, they were sampled from hospital, we had non-random sampling. We have to consider this and report this. They really need to see that. The performance indices, they are like this. They really require to include confidence interval, 50%, 95% confidence interval for sensitivity, specificity, and others. It is so important that even in medical regulations, in CE marking, for example, if somebody would like to design automated external defibrillator, in the guideline for the CE marking, it is said that the confidence interval of 95%, the lower value must be higher than a specific value. So the confidence interval basically says that how the sensitivity is reliable. So if it is too wide, it means that sensitivity is not reliable. So we really have to report all the indices that have a specific explanation in clinical studies. And what is the classical framework that we used? Because it guards against type 3 error. You cannot basically take 50% of the data and train your model and report your result on the other 50%. Because somebody would say that, well, you did it randomly. You repeated this random permutation until you get a very high performance. Then you will have type 3 error. That's why we have to use cross-validation. So we really need, because maybe it's too basic for most of us, but there are a lot of papers published using just this holdout validation, and they do not consider this type 3 error. So that's the problem now that we have with medical data mining, because even for the COVID-19, if you just review, we did the review of all the machine learning methods for diagnosis and prognosis, hundreds of papers. About 60 or 70 papers had problems, basic problems in the validation. So it's like just people were trying to publish the papers without thinking how useful it could be for policymakers or for the society. That's why clinicians do not rely on this, because they have seen so many of these papers. Well, this is another example. It's not really a bad example, just an example. An interpretable mortality prediction model for COVID-19 patient. It's a paper that was published in Nature Machine Intelligence. Right after its publication, a lot of letters were published that this model is not, couldn't be generalized to the population. So the generalization of the model was questioned. And basically the reason was that they didn't use external validation. Balancing the test database. Well, this is the base formula. It's really famous. If you have a sensitivity of 90%, a specificity of 95%, which is very, very hard in most of the medical data mining questions, if you have a low prevalence, the PPV value or the precision value would be very low. And what is the PPV value in terms of statistics? Is the probability that you are really sick when you get your result positive from the system. So it is when your system is applied into the population. So if you have these high values in this plot, and if you have the prevalence of 10%, your PPV is 70%. So it's just 70%. So it's for just 70% of the people whose result is positive, they really have the sickness. So this is one of the issues that clinicians think that machine learning is not good. Why? Because we balance the test data set. Because, for example, the real disease has the prevalence of 5%, but we are designing a system and we know if the number of items in the classes are too different, it's very, very hard to design the system. So we use 500 of the first class, 500 on the other class, and we get a very, very good result. But when it goes to the population, with even these high values, the PPV would be very low. For the regression, we always need to plot Blunt-Altman, which is kind of residual signal analysis. It's like the plotting the average of the gold standard and your prediction in the x-axis, and the difference between your and the error of the prediction. And if you see something like this, it tells you that you have basically different bias in the high and lower values. This Blunt-Altman plot is the clinical paper in Lancet. It is in the top 100 papers in all time, because a lot of people in clinicians use this. Thank you very much. I think I finished it for 52 minutes. Thank you very much.
Thank you very much, Hamid, because you finished on time, so, and it was quite an interesting talk.
Thank you.
And
Thank you.
yeah, so I'm going to check if there is any questions on the chat. No, so far. Yeah, but it was really interesting because we are used to apply any kind of techniques without thinking if it is worth it. It's just sometimes to publish, and instead we should seek making a difference on these health issues and everything. So I think that was a very good point.
Okay, thank you.
Yeah.
It became very important for us. I mean, at the first we were, we are engineers. We like to use the methods, but when you talk with the clinicians, they talk in a different language.
Yeah, that's true. We have to, to agree the terms and everything. The same happens with when we talk about models, for example, in the engineering field, and it's something that is quite different from any other type of model in other sectors. Yeah. So, so I see that your talk has been very much appreciated.
Yeah. Oh, thank you very much.
So, well, then if there is not any question, we can leave it here. So we're going to finish the second day of this workshop or summer school. So thank you very much again, Hamid.
Thank you very much. Thank you, everybody.
Bueno, vamos a clausurar entonces la jornada de hoy, este segundo día de la Escuela de Verano del Comité Español de Automática, que ha sido dedicada a establecer fundamentos de técnicas de la inteligencia artificial y ver su posible aplicación a ámbitos bastante diferentes y todos que tienen una gran implicación social, pues energía, temas biomédicos. Hemos visto temas de visión que van a ser aplicados a agricultura de precisión, temas de robótica, que también tiene muchos, de todo, ¿no? Desde robótica de servicios hasta todo tipo de aplicaciones, como también vimos ayer, ¿no? De exoesqueletos, etcétera. O sea que, entonces yo os emplazo para mañana, que también va a ser, esperemos que una sesión muy interesante, va a estar dedicada a la aplicación de técnicas de la inteligencia artificial en ejemplos concretos. En algún caso se os ha hecho llegar, y si no es así, poneros en contacto con el correo electrónico de la Escuela de Verano, porque se os ha hecho llegar a todos los inscritos un software gratuito que sería necesario descargar si mañana queréis en tiempo real hacer las prácticas o demos que se os van a sugerir. Entonces, bueno, pues además justo son de las aplicaciones en biomedicina. Por lo tanto, si alguno no lo tiene, que escriba un correo electrónico para que se lo hagamos llegar. Y de nuevo a todos, gracias por vuestra asistencia y por vuestro interés. Especialmente gracias a los ponentes que han cumplido con creces las expectativas por los comentarios que estáis haciendo en el chat. Y sin más, pues cerramos aquí esta segunda jornada y espero que nos veamos mañana. Bueno, gracias a todos y buena tarde o buenos días a los que por estar en otras latitudes todavía estáis a lo mejor casi comenzando un nuevo día. Hasta pronto.